afternoon, everyone. I'm Laura, and I am a senior consultant geriatrician working in a restructured hospital in Singapore. And we have started an integrated frailty and intrinsic capacity care model that is adapted after the WHO Integrated Care for Older People program. And we were also actually privileged and honored to have learned from Prof. Angela Leong when she visited Singapore. So moving forward, okay, so a brief outline, I'll be sharing why we have taken an integrated approach to both frailty and intrinsic capacity, how the integrated approach is being operationalized locally, and sharing some preliminary results from the program. So in Singapore, we have actually, as of 2026, this year, become a super aged society where 21% of our population is aged 65 and older, and the number of Singaporeans aged 80 and above had jumped 60% in the past decade. So there is an urgent imperative from a policy point of view to ensure that there are initiatives to support healthy aging in the population. So why an integrated approach? And I think Prof. Zhang had mentioned earlier the definition of healthy aging that places a strong emphasis on functional ability. And this is broadly considered as the capabilities that enable people to be and to do what they have reason to value. We now consider intrinsic capacity and frailty on a common trajectory. Many geriatricians and healthcare professionals are already familiar with the concept of frailty as a geriatric syndrome characterized by diminished physiological reserves that increases vulnerability of the older person to stressors. And this results in consequent adverse outcomes such as falls, disability, institutionalization, hospitalization, and premature mortality. But on the earlier end of the continuum, we have intrinsic capacity represented by the composite of physical and mental capacities an individual can draw upon, and its interaction with environmental factors influences the functional ability of the older person. It has now been recognized that declining intrinsic capacity underlies the diminished homeostatic reserves, culminating in extreme vulnerability of the frail older person. And locally, we have explored the relationship between intrinsic capacity and one-year health outcomes in older adults amongst those who attended a community frailty screening program. So in this cohort of over 800 older adults, we have found that those with high intrinsic capacity at baseline were at lower risk for falls, decline in instrumental activities of daily living, and deterioration in health status at 1 year follow-up. And with this, it is clear that IC and frailty should be considered complementary in the common goal of disability prevention through the maintenance of functionality. In this same cohort, we have also shown that older adults who are yet frail already exhibit intrinsic capacity decline. In fact, IC decline is highly prevalent, such that close to 75% of older adults had decline in at least one intrinsic capacity domain. And this was evident even amongst robust older adults, such that over 50% of the robust older adults had at least two IC domain losses. And with every point decrease in composite intrinsic capacity, the risk for incident pre-frailty or frailty over 1 year increased by 47%. So there is an urgent impetus for us now to consider initiatives or interventions that can address frailty and support intrinsic capacity concurrently. And this brings us to Infinity ICOPE to address gaps in the current frailty screening approaches, with the overarching aim to promote functional ability and minimize care dependency in an aging population. So the current model that we have locally, and I'm also certain also in many healthcare settings, is that we focus on the identification of older adults who are frail. But this may be an overly simplified dichotomization of the older person as being frail or non-frail, which fails to address the complexity of frailty. And objective frailty measures such as gait speed and grip strength are ideal, but may not be feasible in the community. So there is also a tendency to take on a one-size-fits-all multi-domain intervention for frailty that has since been shown in studies may not always lead to frailty reversal or have similar benefits for all older adults because of the heterogeneity. And so with Infinity ICOPE, the parallel IC and frailty screen aims to flag key frailty contributors, as many of the key factors for frailty are closely intertwined to IC domains. We have also developed the technology screening, which provides automated objective frailty measures with a two-in-one gait speed grip strength measure that will support physical frailty assessment in the community. And we utilize the IC framework to identify individual deficits for personalized care. So moving on to the operationalization of Infinity ICOPE, here the platform pivots from just focusing on frailty assessment to also concurrently adopting step 1 of ICOPE to evaluate 6 intrinsic capacity domains for an efficient screening strategy, and older adults are then stratified based on the intrinsic capacity of frailty status, such as either someone with high and stable intrinsic capacity and is robust for primary prevention, mainly lifestyle interventions with behavior nudges, with the aim of maintaining or building the intrinsic capacity and resilience. Those who may still be robust or at most pre-frail but already exhibit intrinsic capacity decline will be older adults flagged for secondary preventive measures with step 2 assessment to clarify the specific intrinsic capacity losses for targeted interventions to reverse, stop, or slow loss of intrinsic capacity. And those already on the frailties end with significant intrinsic capacity losses will require tertiary preventive interventions through comprehensive geriatric assessment at geriatric services hub sites, and I will share on this later, with the intention to support intrinsic capacity recovery or to compensate for losses. So here it is clear, therefore, we use the IC domains to contextualize frailty causes for targeted interventions, whilst the IC framework for frailty prevention allows us to address heterogeneity of older adults. And this is just an example in the figure of the two-in-one screening device that uses LiDAR to capture gait speed as well as grip strength. So Infinity ICOPE adopt a hybrid type 2 effectiveness implementation study design, and with the AIMD framework, the key aims are to maintain functional ability that we measure through the life space assessment as it reflects community mobility and community participation. We aim to deliver Infinity ICOPE with high fidelity, penetration, and sustainability in the community to prevent frailty and improve quality of life. So the key active ingredients for us to support Infinity ICOPE are the need to conduct training of community care providers as well as our primary care providers. So with this, the number of active aging centers that have come on board has been expanding, and we have since trained the staff members and up to 40 community nurses and well-being coordinators in the ICOPE program. Care pathways have been designed for the individual IC deficits and technology with screening as well as an app to support self-assessment of intrinsic capacity. In mechanisms of action, we hypothesize in our causal pathway that the identification of IC deficits and frailty will allow for more timely treatment with person-centered assessment and access to appropriate care and social support, with overarching objectives subsequently to improve IC domains to prevent, delay, or reverse IC losses. But we do recognize that Infinity ICOPE will be a complex intervention, and the success will be contingent upon older persons accepting the IC assessment and recommendations. And it's important that referrals are appropriate and functional to avoid overwhelming existing systems. So for the delivery, we have to also map out the who, what, where, when in terms of roles of each member in the multidisciplinary team, what is being performed by each individual in the team. So what constitutes screening versus intervention, where the screening and the subsequent management or clarification of deficits will be performed from active aging centers through primary care settings as well as day rehabilitation settings, for instance, and the reassessment is performed 6 monthly. So pre-implementation, we engage key stakeholders to first understand also the anticipated barriers and enablers. So in program design, and it's important also for me to share that these are actually stakeholders whom we have been working very closely with in the community for years, even before we started Infinity ICOPE. So there has already been very close working relationship. And so in the program design, our key stakeholders, including staff of active aging centers, primary care providers, community nurses, primary or family physicians, have shared that they do feel that the person-centered approach is important, but they are concerned about older adults' passive health-seeking behavior. In organizational factors, because of the very close working relationship, there was already strong intersectoral partnership, and the community providers valued the targeted training access, which they cited as an enabler. But some of the concerns or anticipated barriers would be capacity and capability constraints, as well as competing priorities and role conflicts, because in our local setting, staff of active aging centers predominantly carry out activities or basically just to register seniors for activities in the center rather than carrying out the role of an assessor. So this requires them to take on or learn a new skill. In system factors, they do value and they see it as an enabler the access to comprehensive information, including information of older adults in their care through the screening, and the initiatives taken by the team to align our program with existing policies, such as Singapore's or the National Healthier SG initiative that was launched recently to support population health. But some of the highlighted barriers include coordination challenges, especially for older adults with multiple deficits and evolving policy changes in the local climate. So sharing some of the services that have been established to support steps 2 to 5 of ICOPE, we have community health posts run by community nurses and well-being coordinators who act as social prescribers. And these health posts are deliberately co-located within active aging centers to bring care close to where seniors live. And they provide health and geriatric assessment, chronic disease monitoring and health coaching, medication education and support, care coordination with relevant agencies, and for those who are more homebound, home visits and teleconsultation. Other services include, as I mentioned earlier, the Geriatric Services Hub. This is actually a community-based comprehensive geriatric assessment for frail older adults run by a multidisciplinary team with family physicians and nurses working very closely with hospital-based geriatricians. The Grace Primary Care Memory Clinics are actually memory clinics situated within primary care settings to improve accessibility to cognitive evaluation with direct access neuroimaging and fast-track access to tertiary memory clinics if indicated. Community psychological health services include, for example, our BRIGHT program to build resilience and self-efficacy for those older adults who screen positive for the psychological domain. And for all older adults, we provide person-centered counseling and goal setting with both conventional education materials, pen and paper for those who are not so technologically savvy, as well as resources made available through our Engage app. So these are the educational resources that are available also through the app, as well as in simple print-out brochures for those older adults who are not so technologically savvy, and in both English and language to accommodate our bilingual older adults. So this is just how the app looks like, and I do not have time to go through how it works, but essentially it aims to support self-assessment and actually incorporates all the step 1 screening questions and can be administered by the older adult without having another caregiver. So this is the multidisciplinary platform where we bring together all our community partners, community nurses, the geriatrician in discussion of older adult, and the discussion plans are then provided or fed back to the participating active aging center so that the staff of the active aging center will know what deficits their members, their senior members are experiencing, and the action plans for each older adult. So moving on to the preliminary findings of Infinity ICOPE, this shows the deficits of identified on step 1 screen for 165 participants that were recruited up till sometime in the middle of last year. And this is still an ongoing program, but the mean age of those participants in this analysis was 72 years, predominance of female and those of Chinese ethnicity. So you can see not inconsistent with existing ICOPE findings that visual deficit was highly prevalent, affecting 80% of our participants. But this may also be the way the question was framed because it was based on the version 1 of ICOPE, where the question do have problems with memory or any chronic disease such as diabetes, hypertension would constitute a positive screen. So if you look at the number of IC deficits, majority of the older adults did have some deficits, with over 80% having at least one IC domain deficit. But if we excluded vision, not because we undermine the importance of vision, but because of the possible oversensitivity of the question, which we have since split up now, the prevalence of those with at least one deficit dropped to just about 50%. So there is a significant association between IC deficit burden and quality of life, as you can see that those with at least 2 IC deficits, whether or not you include vision count, had poorer self-rated health, and they also had poorer quality of life on EQ5D5L. So if you look at factors associated with a high burden of IC deficits, not surprisingly, older adults were more likely to experience higher IC deficit burden. And interestingly, we found that males were more likely to also exhibit higher deficit burden. There was a significant association also with socioeconomic status, as those with incremental deficit burden were more likely to report having difficulty meeting their daily expenses, although there was no association with residence type or occupational status. There was also association with functional performance, but in general, I would like to highlight that most of our older adults are well and functionally independent, as reflected in the high scores on the Bardell Index for Activities of Daily Living and Lawton's Instrumental ADL. But you can see on the life space assessment, progressively constricted life space with incremental IC deficits, and those with at least 2 IC deficits were also significantly more likely to be frail and also more likely to screen positive for being at high risk for oral frailty. So in the diagnostic performance of step 1, this is also somewhat consistent with a scoping review of the diagnostic performance of ICOPE step 1, but you can see generally very high negative predictive values, poorer positive predictive values, and this is not uncommon in settings where you have a relatively healthy cohort with low disease prevalence, but the high NPV may still have utility in ruling out conditions and also to avoid overwhelming downstream services. So in terms of services initiated following screening, close to about a quarter of the seniors required downstream services, with 3 being referred to community services for psychological health, 20 seniors referred to community health posts for frailty or multiple IC deficits, and 14 seniors were referred to Project Silver Screen to clarify their sensory deficits. So at 6-month follow-up, 79 participants had attended. The compliance to all scheduled follow-up was about 44%, and there was improvement in terms of the proportion who reported subjective memory complaints at 6 months relative to baseline, and also significant reduction in their GDS score. There was also significant improvement in self-rated health. So you can see IC status is dynamic as over time, about a quarter had improved, 38% remained stable, and close to a third had worsening IC deficits. And if you compare this against the frailty status, about 50% stayed robust or improved, 30% stayed pre-frail, and about 20% exhibited incremental frailty score. So just sharing some of the perceptions of the older adults who had participated in terms of the innovation. Because of multiple activities within Active Aging Center, they may not directly attribute ICOPE screening activities to our program, but there was overall good perception when we told them that what they had participated in was the ICOPE program. They were motivated to participate and follow up with recommendations. In terms of individual characteristics, what I wanted to highlight was what the older adults spoke about motivation, the need to balance fear and perceived benefits in terms of messaging. So the older adults shared that there is a psychological effect on telling the patient or participant that he is going bad or not doing well. So we should try and moderate the results to them, because if they feel down, they may not want to come back. So in terms of the implementation process, the messaging that older adults suggested was to center it around familism. So because we need to tell people that your health is not yourself, it is your family. If you're not taking care of your health, your family is going to suffer with you. So it's interesting because earlier on, as I shared, in the pre-implementation phase, we were concerned about motivation of older adults, but somehow these older adults themselves shared that they are actually motivated to want to get better and to want to come back. And they do share also that they do have support from their family members in bringing them for follow-up. So in terms of perceptions of the AAC staff and the community nurses, in general, positive sharing that they are able to clearly delineate the role of the AAC staff as step one assessors, whilst the community nurses take on the subsequent care coordination role. So this delineation helps to prevent confusion. In terms of the innovation, general agreement by AAC staff on the components of ICOPE, and they're simple to perform, although nurses did share concerns about accuracy of the screening approach. In general, the AAC staff and nurses did not perceive any difficulty in conducting the screen, and they were motivated by the perceived benefits that older adults will receive. So the enablers cited again, shared were the seamless communications and relational connections, although again, one of the barriers highlighted was the lack of manpower in AAC and staff turnover. And challenges that AACs face also with new service boundaries, and they do lack certain clarity in future directions planned by the wider healthcare system. And these are important considerations that we do take into account. And in terms of implementation process, it's important that they feel that the adaptation of ICOPE and our flexibility was helpful in allowing the program to be conducted locally. So this is my final slide. Towards integrating care at the population level through Infinity ICOPE, the regular reassessments will be important in allowing us to recognize transition for timely intervention, and recognizing when significant losses of IC require long-term care services, understand the evolving population needs through proportion of population with decline in intrinsic capacity, and ultimately to support policy changes through evidence-based information on effects of Infinity ICOPE interventions. And we had officially launched Infinity ICOPE in SingHealth back late in October 2024. With this, I thank you for your attention.